No, we'll discuss adult vaccination once again in detail. So we'll come back to both. Yes. So we have the most interesting session of the day, and that is clinical presentation of different types of pneumonia, and we have none other than Dr. Nagesh for this deliberation. He is known for his intelligence, wit, and wisdom. So welcome to you, sir.
ಯಾವುದಿದೆ ಫಾರ್ವರ್ಡ್ ಇದೆ ಗುಡ್ ಆಫ್ಟರ್ನೂನ್ ಫ್ರೆಂಡ್ಸ್. Good afternoon, friends. Respected senior pediatricians, Dr. Kashi, whom I consider him as my guru and whom I look up to for everything, Dr. Vasudev Dhananjay, Dr. Satish Rao, then Dr. Gnan Murthy, and my fellow colleagues, pediatricians.
You are not senior, huh?
Sorry? Sorry?
He objects to the word senior being used for it.
At the outset, I would like to thank Dr. Manjunath for giving me an opportunity to be part of this pneumonia conclave. Thank you, Dr. Manjunath. And I thank Pfizer also for sponsoring this particular meeting. The topic that is given to me is clinical presentation of different types of pneumonia. I don't know why Dr. Manjunath gave me this topic, because all of you know the clinical presentation, all of you know the symptoms and signs of pneumonia. I don't think this session was really required. But having said that, see, the crux of my talk would be to sensitize whosoever has come here, to pick up pneumonia early, that's it. Once the child has developed pneumonia, well, that's not a big deal, the child has a consolidation and all that, even the patients can diagnose it themselves. In fact, before starting this talk about a week ago, I was just checking with some of my patients. I just asked them, ಕನ್ನಡದಲ್ಲಿ pneumonia ಅಂದ್ರೆ ಏನು ಗೊತ್ತಾ? ಗೊತ್ತು ಸರ್, ಹೈ ಫೀವರ್ ಇದೆ, ತುಂಬ ಕೆಮ್ಮು, ಉಸಿರಾಡೋಕ್ಕೆ ಕಷ್ಟ. ಕರೆಕ್ಟ್, ಹಿ ವಾಸ್ ರೈಟ್. ಅವ್ರು ಹಿಂದಿಲ್ ಕೇಳಿದ್ರೆ, ಎಸ್ ಸರ್, दम पकड़ता है ना, बच्चे को फसली उड़ता है ना, वही है, तेज बुखार, खांसी है. So that means they already know the clinical presentation. But we, the pediatricians, we are supposed to pick up pneumonia much before the child develops some of these.
I wanted you to present because you have this narration.
all right. Yeah. See, this is the overview of my presentation. Yeah. Introduction, etiology. You may be wondering why Dr. Nagesh is also is going to talk about etiology, but I thought this is relevant to my talk. So definitely I'm going to spend few seconds or maybe less than a minute in the first few slides. Then I'll come to history, physical examination, differential diagnosis, complications, some take-home messages which I thought is relevant. And there'll be one audience question. Please wait for that. Okay? Right. Introduction. Pneumonia, as we all know, is one of the leading causes of morbidity and mortality in children under 5 years of age and beyond also. And in fact, I was listening to Dr. Kashi the last week webinar. He was also just telling, nowadays the streptococcal pneumonia may not be the leading causes anymore with post-vaccination. Other viruses may be contributing. So like RSV, he was mentioning about RSV also. Maybe the time will come that we may have to vaccinate most of our children with RSV when the prices do come down. And if memory serves me right now, in the 90s and all that, when Pranita and Srilekha, they were students, rather I would just call them my colleagues. I was the staff there in Vanivilas. I still remember those days in Vanivilas. The wards used to be filled with cases of pneumonia. Srilekha ಬಂದರೆ ಸರ್ ವಾರ್ಡ್ ನಂಬರ್ 1 ತುಂಬ ಚೆನ್ನಾಗಿ ಬ್ರಾಂಕೋಫೋನಿ ಕೇಳಿಸ್ತಿದೆ ಸರ್, ವಿಸ್ಪರಿಂಗ್ ಪೆಕ್ಟುಲೋಪಿ ಕಾಣಿಸ್ತಿದೆ. So many cases. Our procedure used to be filled with children with the empyema. We used to drive so many children and all that. But there is a definite change now in the last, say, definitely 5 years with the introduction of that. Even I spoke to Dr. Sahana also, even she said the same. So definitely the incidence of cases of pneumonia as well as complications has definitely come down. I just wanted to give clarification on few terminologies. See, pneumonia and pneumonitis can be used interchangeably, but we clinicians generally do not use the term pneumonitis as a diagnosis. It's mostly used by the radiologist. You would have seen the radiologist report paracardiac pneumonitis, basal pneumonitis. Basically, any inflammatory condition that involves the lung parenchyma should be called as either pneumonia or pneumonitis. But one should be very careful, because I see in so many discharge summaries, they use the term LRTI. The parents are told, "Nin magug pneumonia bandito." This is something wrong. I don't agree with that. LRTI should not be used interchangeably with pneumonia, because it's such a broad and non-specific term. It encompasses so many other conditions. It should be avoided. We all know that pneumonia is an invasion of the lower respiratory tract by pathogens, either by inhalation, aspiration, epithelial invasion, or it can even be bloodborne also. But trust me, my dear friends, most of the typical bacterial pneumonia that we see in our day-to-day practice is not due to upfront one bacteria is entering your body and causing that. No, it is generally due to aspiration or inhalation of the colonized bacteria in the nasopharynx. I always used to wonder, these streptococcus, they were sitting very quietly there. Our immune system is not doing anything to destroy them and all that. I was just going through the many textbooks and all that. And one more thing, that's a disclaimer. I am not a tech savvy person, and I have not really consulted AI and all that. I just read many textbooks in the last 1 or 2 weeks. Based on that, I made these slides. So why these, the streptococcus pneumonia, which are the pathogens sitting inside the without causing a disease? Then I just going through these books. Now it mentions that there is something called an immune tolerance. There's a small group of bacteria which is present is there. Our immune system do not kill them. Okay, so it is under the check. It is under check, and it does not kill them. By killing them, we are causing a lot of inflammation. So obviously our immune system does not want to cause tissue damage. So this is one. Second one, we do have other microbial flora in the nasopharynx. So they also compete for space and nutrients. They do not allow these bacteria to grow. The third one is we do have local IgA. It keeps a vigil on this. So because of these 3-4 reasons, these bacteria generally do not cause the disease. But when they are inhaled, when they are aspirated into the lungs, things will change. Now they have a gala time there, because now there is no check. Immune system, immune tolerance is gone. As soon as they enter the alveoli, they start multiplying in large numbers. A lot of oxygen is there, vascularity is there, and there's no immune check. But here, two terminologies we should remember. There is something called switch phenomenon and the quorum sensing. What is the switch phenomenon? Probably due to our low immunity, or maybe the pollution or the preceding viral infection, they activate their genes. When they activate their genes, there's an upregulation of virulence factors and their pathogenicity increases. So that is when they start multiplying large numbers and start causing tissue damage. And what is this quorum sensing? So once they have reached a particular level of the bacteria, then they start communicating with other bacteria. Well, now we have reached a quorum. Come on, let us now start our unruly behavior. So in fact, I would like to give an analogy here. We have so many illegal immigrants in our country. They have a fake Aadhaar and all that. I just, they are like our nasopharyngeal flora. Sometimes something triggers from somewhere and all that. Well, now there is a switch and they start multiplying. So I just give the same example. See, look at this, colonizer becomes a pathogen. So this is how now the inhaled bacteria becomes a pathogen and start causing pneumonia. So the next one, I would like to spend few seconds here in the etiology. Of course, this is a very busy slide. If we just look at bacteria, just only 2-3 things I just want you to concentrate. Chlamydia trachomatis and Chlamydia pneumonia. You are seeing two bacteria. Trachomatis is mostly seen in the first half of infancy, whereas pneumonia is mostly in the 5 years and above. And viruses, of course, you are all familiar with RSV and all that. And these viral infections, they continue to cause pneumonia till the age of 5 years, just not in infancy. You should remember that. And fungi, it's mostly in children with immunocompromised state. See, etiology is different in different age groups. It's already been talked about by the previous speakers. And in newborn period, it's mostly the gram-negative bacteria. Post-neonatal period, it's mostly the viruses which cause pneumonia. But among bacteria, it's mostly the Streptococcus pneumonia, which is the common cause of pneumonia. But now there is an epidemiological shift. Post-vaccination and all that, we will probably be seeing other bacteria predominating. It may be even mycoplasma, it may be the viruses also. So the cases of pneumonia, they start increasing from the age of 5 years onwards. Tuberculosis should be kept in mind at all age groups. Aspiration pneumonia, you should remember that it is caused by the oral flora, anaerobic oral flora. Organisms in immunocompromised individuals is the same as in immunocompetent children, plus they are also susceptible to opportunistic infections caused by fungi, pneumocystic gyrovesi and other the viruses. In cystic fibrosis, it's mostly Pseudomonas and Aspergillus. In sickle cell disease, it's mostly Mycoplasma and Chlamydia. So having known a little bit about etiology, now let us look at pathophysiology. Pneumonia is essentially due to three things. You should just remember only three factors. One is if your immune systems are impaired, or if you are invaded by a very virulent organism, or if there is a overwhelming inoculum, invasion by overwhelming. Just remember these three factors. But God has been so kind to us. He has given us fantastic natural barriers. In fact, I compare these natural barriers to our armed forces. Like we have three things of armed forces, we have three. One is the anatomical barrier. Just I compare it to land, the army, and we have navy and air force. Like that, we have cellular immunity and humoral immunity. I'm not going to talk about cellular immunity. Here, I just found few things in that textbook. I thought I'll just share it with you. In anatomical barriers, we know that the God has given us 23 generations of the bronchi. So if at all the bugs have to enter, it has to cross 23 generations to cause pneumonia, the lower down. And of course, from the third generation onward, they lose their cartilage, they become bronchioles. From the 16th generation onwards, we have alveoli, we have respiratory bronchioles, alveolar duction. So here you can see that there's a dichotomous, the branching of the tree, bronchial tree. It's very difficult for the bacteria to get colonized. So this is one defense that we have. So the second one is, and we are also endowed with about 20 to 150 million alveoli at the time of birth. But as we become an adult, it almost like 3 to 4 times that. And friends, there's one more thing. See, we have this nasal hairs here. And I just going through that the Kendick textbook, he mentions very clearly, we are born, we have something like 100 to 120 vibrissae in our, they're the long stiff hairs. In fact, there was a study which was conducted, they mentioned if the density of vibrissae is more, the incidence of pneumonia, asthma and the allergic rhinitis is less. So friends, don't pluck it out. If you want, you can just trim them so that you probably are not prone for many infections. If these natural defense barriers are breached, then you get the infection. Infection leads to inflammation. What the inflammation will lead to? Either to injury or death of the alveoli, the epithelium. Air spaces get filled with the cellular debris, and the decreases lung compliance. There's collapse of small airways and air trapping and altered VQ ratio. Sometimes severe infection can lead to necrosis, like what we see in necrotizing pneumonia. This is in brief about the pathophysiology. And we all know, when the bugs enter, they are not causing fever, but we elicit, there is an inflammatory reaction in our body, and we release the interleukins. IL-1 and TNF, that results in fever, and IL-8 and the granulocyte colony stimulating factor, that produces both neutrophilia and purulent secretions. Capillary leak happens, that results in infiltrate, which is what you see as pneumonitis on the radiology, and that is responsible for crepitation that is heard. And hypoxemia, we all know it's due to the filling of alveoli. This is in brief about pathophysiology. Now I come to the main topic. Before I just talk about the clinical features of pneumonia, I thought I'll just mention about different classifications we have, that in the context of the talk. 4 pathological stages, which has already been talked about my previous speaker, Dr. Pranita, I think spoke. Stage of congestion, stage of red hepatization, grey hepatization, and stage of resolution. Of course, if everything goes well, the child will have a stage early. Sometimes it's not, all is not well, and it doesn't end like this, they lived happily ever after. No, it may not happen like that. But some unfortunate children, the healing is not ideal, and it leads to a lot of complications like empyema, abscesses and nematocysts and all that. So this is one classification. And of course, we do have a pathological patterns, Either the child will have a lobar pneumonia, any lobe can be involved, or there can be bronchopneumonia, the bronchopulmonary segments, which you have 10 on the right side, 9 on the left side, that can be involved in patchy pneumonia at broncho. If we can have a necrotizing and caseating pneumonia, and we can also have interstitial pneumonia. So these are the patterns of pneumonia. This is what I am interested in now. I will be talking about this. One is typical bacterial, atypical bacterial pneumonia, viral pneumonia, then aspiration pneumonia, fungal and mixed pneumonia, wherein the viral infection is followed by a bacterial infection. And it will be incomplete if I don't mention about the WHO classification of pneumonia, where WHO has given a lot of importance to respiratory rate, because respiratory is something, it's reproducible. There is no interpersonal, the difference. Whereas when it comes to auscultation, that I might differ with my colleague. So here RR is given, it is meant mostly for community health workers. And we know the below 2 months, if it's more than 60 breaths per minute, it is tachypnea. Then 50 breaths per minute, 2 months to 1 year, 1 year to 5 years, it's about more than 40 breaths per minute, more than 5 years. We are all aware of that. And WHO has classified it into pneumonia, where there is just only tachypnea, which can be managed as an outpatient. Then a severe pneumonia, where the child has a fast breathing, plus the child will also be an altered sensorium, child is vomiting severely, the child may be having convulsions, inability to feed. And this particular chart, it summarizes whatever I told you. In mild pneumonia, the child is reasonably normal. Normoxemia is there is no desaturation there. Whereas when it comes to severe pneumonia, as you can see, there is hypoxemia, and the capillary fill, and the child may be in a state of shock as well. So that's about the WHO classification. And of course, there's another classification is community acquired pneumonia, which is what I'm going to really, I'm referring to now. Healthcare associated pneumonia, nosocomial pneumonia, ventilator associated pneumonia. Of course, this is beyond the scope of this discussion. So now comes the clinical features and presentation of pneumonia. What is the very goal of this particular talk, or why are we sitting here and discussing about pneumonia? Our goal, the primary goal, is an early diagnosis of pneumonia. We will see how best we can do that. And if possible, identify the specific pathogen and the etiological agent, so that your treatment becomes complete. You can narrow it down to a particular etiological agent. And to diagnose pneumonia, first of all, you should have a very high index of suspicion. In a given patient, you should ask yourself, can it be pneumonia? So how do you diagnose Kawasaki disease? You have a high index of suspicion. There is no lab data which will support you. So likewise, even in pneumonia, first of all, you have a high index of suspicion, then you will be able to pick up pneumonia. And of course, now in this presentation, we'll be looking at signs and symptoms of acute infection of the lung. I'll be confining myself to community acquired pneumonia. Before we talk about the individual type of pneumonia, let us look at the common features. As I said earlier, we know that the common features are high fever, cough, and respiratory signs and symptoms. And more often than not, the symptoms of pneumonia in the initial stages are very non-specific. As I said earlier, in any given patient, a child walks into your clinic with a very high fever, you have to ask yourself a question, can this be pneumonia? Just like you ask yourself a question, can this be Kawasaki disease? And trust me, there is no single sign, single symptom or a lab test which is pathognomonic of pneumonia. No. And infants and children, that is where the diagnosis is really difficult. A crying child comes to you with fever, you cannot even measure their respiratory rate. This is where one can miss the pneumonia. One should be very careful, have patience, just allow the baby to sleep in the mother's arms, and then slowly look at the babies. You can pick up the grunt and all that. So infants and young children, they can present you only with feeding difficulties, and they have very subtle symptoms and signs. This is important. Concentrate on this. Some children will have only high fever. This sentence will come again in my take-home messages. But when you have a high fever or toxic-looking child, you just do a CBC and you find that there's a leukocytosis, acute phase reactants are elevated, and later you do a chest X-ray in the next 24-48 hours, you find the child has a pneumonia. But the child did not have any respiratory signs. This is the stage that we should pick up pneumonia, right? So it will reveal. They can also present with acute chest pain, high fever, acute chest pain. Your differential diagnosis should be, because parents will ask, sir, can it be heart attack? No, more often than not, fever with chest pain in pediatric age group, unless it's mostly the pleurisy pain it is. And they can also present with acute abdominal pain, the phrenic nerve, they can also the referred pain in the abdomen. And they can also have neck stiffness if the upper lobes are involved. So now comes the common clinical, I just continue here.
Nagesh, on the extra point, some of the kids with pneumonia, they may not have cough at all.
Yes, cough may not, in fact, if the cough is present, it may not be pneumonia. More often than not, it can be wheezing. So the cough is not the correct. You are absolutely right. Point well taken, Dr. Vasu. And the detailed history taking is extremely important. This I cannot overemphasize anymore. So listen to the parents, even spend some time, the duration of illness, whether they have traveled to some different places, baseline health before the onset of the illness. There was a history of contact with people with flu, people with even mycoplasma also. There was some child was coughing about 2 weeks ago, or the child is going to school, or there is a history of contact with tuberculosis. History of recurrent symptoms. If the child is having recurrent pneumonia, be very, very careful. Even second or third attack of pneumonia, probably either you are dealing with congenital malformations or it may be inborn errors of immunity also. Like, sorry?
Or fine, but
Yes, and the choking, yeah, that's just coming to that. History of choking, foreign body. Then take the immunization history. If the child has not received HIV, you are going to even think of Haemophilus influenza is also one of the causes of pneumonia, and other pneumococcal and the influenza vaccination. Birth complications, if the child was ventilated, there's a possibility the child had a BPD, bronchopulmonary dysplasia. So this particular chart summarizes whatever I told you. Then physical examination. Inspection is important. You don't have to touch the child, look at the child, whether the child is drowsy, breathing very fast, respiratory rate, whether the child is, is able to eat or drink. And older children, the mental status, the child, they will tell you, sir, first time I noticed the magu high fever, tumba sustagidane, yavaglu malkonde irtane onthara drowsy agidane. That's a very important symptom. Please give cognizance to all these symptoms. Don't brush it aside. And then when you are examining, look at the SpO2, whether the child has a normoxemia or a hypoxemia. Look at clubbing, that means the child has already developed a complication. There is an empyema. So in detailed respiratory system, this is one thing, please know in any given child, do whatever Hutchison has told. That is inspection, palpation, you may not do that. You can do percussion, please do auscultation. Sometimes you will be thrilled to find a bronchophony, bronchial breathing. There may whispering, pectoraloquy. So all those things, right? So do the detailed examination. The same thing is summarized in that particular chart, whatever I told you. Now we shall discuss the clinical presentation of different with this background. And I will also walk you through a type of pneumonia called walking pneumonia and afebrile pneumonia of infancy. These are the two atypical presentations. So this is a chart now which is depicting everything, whatever I am going to tell you in the next few minutes. That is how does the typical bacterial pneumonia present with the clinical features and the radiological, atypical, the viral, then the afebrile pneumonia of infancy, fungal and Mycobacterium tuberculosis. Now comes our hero. This is what we generally are familiar with. Streptococcus pneumonia, the typical bacterial pneumonia. I can even use the TBP. This is seen in children in all ages. We thought streptococcal pneumonia is only common below 5 years. Even beyond 5 years, still that is the dominant bacteria. And of course then comes other atypical bacteria. They usually present you with abrupt onset of high fever, chills, chest pain may or may not be there, cough may or may not be there, moderate to severe respiratory distress can be present. They look toxic, underline this. This is quite important. The respiratory signs may be present. In some children, in one of those studies, I'm just going through the textbook, the child can present with hypothermia. If the child is already gone into sepsis secondary to the pneumonia. So it is so overwhelming, the child may not have fever. On the contrary, the child may be having hypothermia. One should be very wary of this. And they may present to you in shock also. Once again, here the diagnosis, you just think in that individual child, can it be bacterial pneumonia? Yes, it's possible. It's done with high index of suspicion. Please do a lab evaluation. When you do that, what do you find? Leukocytosis, neutrophilia and high CRP. So now that you'll have to raise your antenna now. It could be pneumonia. Then you do an X-ray. Always, I'm going to quote one study wherein a child who had a very high CRP, toxic looking child, there is a role for doing, even role for giving an antibiotic itself or doing an X-ray. X-ray should be our first investigation. Sometimes initially you may not find anything, but in many children you start noticing infiltrates in the lung. So that means you are already diagnosing typical bacterial pneumonia so that you can start your antibiotic early before the child develops complications. So important message here is, in a given child, please, if you're suspecting typical bacterial pneumonia, do CBC, do acute phase reactant. Please do blood culture also. Many a times we do all unnecessary, irrelevant investigation. We have to pay. What do? Dengue profile, typhoid dot, all those things. Really, that is not very important. Trust me, you can pick it up later and that's not a life-threatening. So, at least in the beginning it may not be life-threatening, and do a chest X-ray if indicated. This is how you pick up pneumonia. So these are the very classical, the X-rays of a bacterial pneumonia. You can see the lobar consolidation, the upper zone. The same thing here, this side you can see the necrotizing pneumonia, the one on the left side. If it is not diagnosed early, what will happen? You will end up seeing complications. Effusion, empyema, necrotizing pneumonia, or even you will also start nematocele. What are the common bacteria implicated? Strep pneumonia, HIV in unimmunized children, staphylococcal pneumonia, both typable and non-typable HIV also. Now comes the second type, which is atypical bacterial pneumonia. When do we see atypical bacterial pneumonia? It's mostly seen in children who are in the school-going age group, 5 years and above. But that is changing definitely. We are seeing many cases of atypical bacterial pneumonia in younger children, even in infants also we are seeing mycoplasma pneumonia. So please keep that in mind. Initially they have a milder symptoms. Generally it's a very gradual in onset. Rarely it can be abrupt in onset. And they can present with all this myalgia, headache, conjunctivitis, rashes, sore throat, photophobia. In that Kendick books, he does mention this particular, what I have highlighted. Even you can recollect, you can go back and recollect in many patients. Sometimes they tell you, sir, nange ಸ್ವಲ್ಪ voice change ಆಗಿತ್ತು, ಗಂಟ್ಲು ನೋವಿತ್ತು, then I developed cough and fever. That cough is a typical mycoplasma cough, either it's a whoop kind of a cough or it's a staccato kind. So in this particular instance, initial manifestation, and another very important thing is, usually mycoplasma, you don't find rhinitis. So that is, it's conspicuous by its absence. So if the child has pharyngitis, hoarseness, absence of rhinitis, then the child will have fever and persistent cough. That is a clue to the diagnosis of mycoplasma. More often than not, you will get away by just giving macrolide in a macrolide sensitive mycoplasma pneumonia. And of course, the mycoplasma, it was discovered by Dr. Eaton. So it's also called Eaton agent. As the name itself says, sometimes you will see in the next slide, it can eat away almost all organs in our body. It is not that innocuous. And if we have the habit of looking into eardrums in all children with fever, in mycoplasma, you will find bullous meningitis. This is one of the very diagnostic of mycoplasma. And they lack cell wall, we all know that. That's why they don't respond to penicillin. We need to use other antibiotics which do not act on the cell wall, like fluoroquinolones and tetracyclines. Characteristically, this is important. They do not have toxicity. Generally, no distress. So the child is able to walk and all that, but the child keeps coughing. That is why it gets its name, walking pneumonia. In fact, we did read in newspapers in China, there was an outbreak of walking pneumonia a couple of years ago. I'm going to cite that study also. And this atypical bacterial pneumonia can also present with extrapulmonary manifestation. You should be wary of all these symptoms. So they can have a polymorphous mucocutaneous eruptions, they can have mycoplasma-induced rash and mucositis, Stevens-Johnson syndrome. You name an organ, all organs are involved. They can have hemolytic anemia, they can have encephalitis, all kinds of neurological problems, and they can have all cardiac complications, right? Here the lab evaluation, it's generally unremarkable. Chest X-ray, usually it shows reticulonodular infiltrates. It can also show segmental consolidation, and any type of pneumonia can be seen. I will show you certain few X-rays, X-rays which was taken by Dr. Shrikanta. He shared those X-rays. I will show you in the next slide. The common bacteria of atypical pneumonia are all generally mycoplasma and chlamydia, and rarely Q fever, tularemia and anthrax. They are also classified under atypical pneumonias. See, and this point you need to remember. I think probably Dr. Keshav is going to tell us, So sometimes they don't respond to your antibiotics. So the infection is gone. But some of the symptoms are immunologically mediated. So that is why there is a role for steroids even in these children. Right? It can be immunologically mediated, and it can be toxin mediated also. There is a type of toxin called CARDS-TX, community acquired respiratory distress syndrome toxin. It binds to surfactant protein A. Unfortunately, the incidence of complications following mycoplasma pneumonia nowadays is relatively high. We are seeing so many children with a lot of complications. And the worrisome thing is, it is resistant to most of our macrolide antibiotics. Now we have to use the second line, either doxycycline or levofloxacin, fluoroquinolones. See, these are the X-rays. Don't you think it looks just like a typical bacterial pneumonia? So this is the presentation. So there in the Dr. Shrikanta shared me all these X-ray, his own for the patients, right? So one should be very careful. And here I would like to know the mention about afebrile pneumonia of infancy. As the name itself suggests, these children, they don't have fever. It's generally seen in younger infants, usually about 2 to 4 months of age. The typical history is, no, it's very insidious onset. They generally don't have fever. They will have a little bit of a runny nose. Conjunctivitis is the thing, So the child can have conjunctivitis or might have had conjunctivitis, or the mother might have had conjunctivitis. That is a clue to the diagnosis of this atypical pneumonia of infancy. And the characteristic thing is day 3, day 4 they develop staccato cough. What is staccato cough? A single individual cough separated by inspiration. That kind of a thing, So that kind of cough, and rarely they can also have a little respiratory distress. On examination, you will find crepitations mostly, not much of a rhonchi, mostly crept. This is where if at all, one of your friends has already helped you with the CBC, if you just low-coat the CBC, you will find eosinophilia. Right? That is a clue to the diagnosis of this afebrile pneumonia. And of course, generally they are managed with few doses of the azithromycin. It works wonders. We have seen such cases in our practice. I'm sure we have all seen that. The third variety is viral pneumonia. This is one of the most common maladies that affects infants and children across all age groups throughout the world. And of course, now probably in future the shift will be towards viral pneumonia rather than bacterial, because now we have started conquering many the vaccine preventable diseases, the pneumococci and HIV and influenza as well. Usually seen in children below 5 years, the onset is generally gradual. They have a preceding URI symptoms. Systemic toxicity is not that common in viral pneumonia. Why? The reason is most of the respiratory viruses do not cause viremia. That's the reason. And they may have a viral exanthem. Wheezing may be present both in bacterial, the viral pneumonia and the mycoplasma pneumonia. The clinical presentation of viral pneumonia is usually the same thing, tachypnea, retractions, and we should also remember it can also be confused with bronchiolitis. If you just go back to our undergraduate Achar, always there used to be short note, difference between bronchiolitis and bronchopneumonia. So that's one of the DD. But in a typical case of an ILA, influenza-like illness, they present little differently. Sudden onset of high fever, myalgia, sore throat, severe cough, and suddenly they can progress to that is the influenza pneumonia. And generally it runs a benign course, except in some cases of RSV and influenza where it can really run a very stormy course. The common sequelae that you see in bacterial pneumonia, like an effusion, empyema, you don't see that in classical viral pneumonia. CBC may be normal, or it may show leukopenia or lymphocytosis. Chest X-ray usually shows that interstitial infiltrates, hyperinflation, and patchy atelectasis. This is the study I was talking about. There was a retrospective study. It was done in China. About 800 children were enrolled. They did this PCR in almost all the children, and they wanted to differentiate, see if there are any clinical features which can help us in diagnosing mycoplasma versus viral pneumonia. Their findings in that study was children with mycoplasma had hyperthermia, and the median age was 4 to 5 years. We also agree with that. But they had a longer hospitalization with higher hospital cost. Diarrhea and vomiting they were not seen. They were seen mostly in viral pneumonia. Lower WBC count, lower lymphocyte count, and they had a high eosinophil count. And there's one more thing, eosinophil cationic protein. And their PCT, procalcitonin level, was low. So the strength of the study is, as I said earlier, they did apply multipathogen PCR in all children, but it's a single center study with only 79 cases. They did not do extensive microbiological test. Another retrospective was studied. There were so many studies. When I just went through the net and all, there were so many studies, but unfortunately the conclusion is no clinical or radiological characteristic was helpful in diagnosing different types of pneumonia. Right? Now comes the fourth type, fungal pneumonia. Fungal pneumonia, as we all know, it is mostly seen in children who got an immunocompromised state. It can be CGD, chronic granulomatous, or neutropenic children, or even cystic fibrosis. Here the prototype that we see is Aspergillus pneumonia. Typically, they do not have an acute presentation. It's mostly subacute or chronic. The symptoms are the same as in typical pneumonia, but the setting is different. You know that if a child with already some immunodeficient disorder, you will make a diagnosis. And in one study, a child who had a pleuritic chest pain and hemoptysis, that was highly suggestive of pulmonary aspergillosis. So chest X-ray generally shows mediastinal adenopathy. In tubercular pneumonia, we all know that it can affect any age, all age group children are affected. They have a chronic cough, they have a constitutional symptoms, there's a history of exposure, and chest X-ray shows mediast. Of course, we are not going to discuss about tubercular pneumonia. Aspiration pneumonia, we know there are two types, acute and the chronic. Chronic is mostly in those children with neurological handicaps, with a chronic GERD. Mixed pneumonia. Here I would like to spend a few extra seconds here. See, viral infections more often than not, they followed by secondary bacterial infection. In one particular study, they found that 50% of community acquired pneumonia it is mixed. So they had a viral infection in the few days earlier, then the child developed bacterial pneumonia. Why? This is one of the reasons is viruses induce what is called they enhance the bacterial adherence. They have a good bond harmony. Their camaraderie is very, very good. In fact, I already created a crater in the lungs, you go now. So they got a fantastic understanding between them, which sometimes we don't have. So these bugs they really work in unison. Example is influenza and streptococcus pneumonia. That's why Dr. Kashi was always telling, if you vaccinate a child with streptococcus, the influenza, you can also prevent streptococcus pneumonia. So that's about the different types of pneumonia. In brief about differential diagnosis. Of course, the differential diagnosis, the simple URI, sometimes the parents are brought, the children are brought to us by the parents with, could it be pneumonia? Because the child has a severe nose block, the child cannot breathe. But you have to differentiate URI from pneumonia, bronchiolitis. Asthma and viral URI sometimes does come in the differential diagnosis of a pneumonia. Sometimes it can be confusing when in a hospitalized child, they give frequent nebulizations and antibiotics, but at the time of discharge, you will make a diagnosis of only asthma, exacerbation triggered by a viral infection, but they can masquerade as pneumonia. Foreign body aspiration, CCF, and metabolic acidosis, especially a child with DKA with metabolic acidosis comes with high fever. Sometimes even we are taken for a ride. You have to be very, very careful when there are no lung findings. Then if you just look at the child and acidotic breathing, that is how we make a diagnosis of DKA. And of course, the non-infectious causes like a vasculitis, hypersensitivity pneumonitis, which is mentioned in that the chart, can also present with pneumonia. Complications of pneumonia. If you do not pick up pneumonia early, if you do not treat them in the beginning, these are the complications. Can have effusion, empyema, and necrotizing pneumonia. Here I would like to stop and talk few things. I would like to give you a few points. We all know that necrotizing pneumonia is caused mostly by Staph aureus. It can also be caused strep pneumonia. There are 2-3 types. Of course, Dr. Kashi is aware of that. These 2-3 serotypes, they are really very virulent. So especially Streptococcus pneumonia number 3, it also gets a beautiful name, sugar-coated killer. Okay, so it has got a thick, big capsule, which can even evade opsonophagocytosis, and it can cause whole lot of complications. Same thing with Streptococcus pneumonia 1. I would call this the pneumonia as a jihadi, because it may not get killed, but it will undergo autolysis. It will undergo autolysis and release large quantities of pneumolysine and start destroying our the parenchyma. Same thing holds good for 19A and 14 also, and aspergillosis can also cause necrotizing pneumonia. And of course, other complications are lung abscess. You can see that in the second X-ray, pneumosepsis, shock, and multi-organ dysfunction syndrome. Now comes the prognosis. Prognosis is generally good if you have picked up pneumonia early and if you have managed the child quite early. And if there are no other the predisposing factors, generally the prognosis is good and managed, diagnosed and managed early. But of course, some staphylococcal infection, children with varicella pneumonia, children with inborn errors of immunity, and children with comorbidities like a CSD, BPD, and the sickle cell disease, asthma, GERD, may have a guarded prognosis for obvious reasons. Now comes my few take-home messages, which I've already told you in the course of my presentation. Fever may be the only presentation of pneumonia. Please remember this. There were 2 studies I was able to get. One study in Australia, 30% of the children under 5 years, they presented with only high fever. When the pediatrician on duty did CBC and CRP, he found that the child had a leukocytosis and high CRP. Next day he does an X-ray, you find the child has a lobar pneumonia. So, mind you, and similarly, there was a study from US, they showed 70% of children that had only high fever, absolutely no respiratory signs, but found to have had a diagnosis of pneumonia the following day. So in rural Uganda, in addition to the symptoms of the pneumonia, they were giving antibiotic which goes to only symptoms of pneumonia with a high CRP. So CRP was given a lot of importance in that particular study in one Ugandan area. So remember this, fever may be the only manifestation. With only your high index of suspicion, you can pick up. Presence of grunting, we all know, is a sign of a severe disease and impending failure. You have to immediately hospitalize the child. Of course, the probability of pneumonia is always high when the child has other respiratory signs like head bobbing, nasal flaring. Wheezing, as I told earlier, is most frequently associated with viral and mycoplasma pneumonia, not with bacterial pneumonia. Then tachypnea, I told you, it's a very useful sign and for the diagnosis of childhood pneumonia because it's more specific and reproducible than auscultatory findings. Children with pneumonia need not present with all the classical signs and symptoms. Pneumonia is often misdiagnosed, it is underdiagnosed, and the third is also important, mistreated. Somebody will call it pneumonia, but the child is given Taximo. 48 hours later, the child comes to you with complication. So that is a child is probably not appropriately treated. So a combination of excellent history, physical and respiratory examination, high index of suspicion and relevant investigation, quickly you triage and then you do all these things in the first 24-48 hours. That is the key to early diagnosis so that you can prevent the complications. We have already seen that infants have very subtle signs and symptoms. Be very careful. There is no single symptom, I told you, or a sign which is pathognomonic of pneumonia. Don't wait for all the symptoms to appear and then make a diagnosis. So diagnosis of pneumonia should be restricted only to a condition associated with there is an evidence of parenchymal involvement. You don't call bronchitis as a pneumonia. This is important. This is only out of my experience I put this message. What is? A stormy initial presentation should rise there. I have had at least 3-4 children who presented me with a very stormy course. Morning the child came with high fever, evening the child was looking very drowsy, had already severe cyanosis, the child was in a moribund state. The child was hospitalized in ICU. 48-72 hours later, the child deteriorated in spite of the best of antibiotics. And that is when we had a discussion with the intensivist. I requested him to do an IVIG before to continue the treatment. Already by then the child had gangrenous changes at the end of 48 hours. Then the IVIG report came on day 3. The child had very low levels of all immunoglobulins. It was a Bruton's immunoglobulinemia. But by then, unfortunately, the child had developed gangrene. We had to do amputation below knee. Even now, I'm following up that child. It was about 7-8 years back. So, first, and then, of course, when I went back to the history, the child had a very mild pneumonia about 6 months back. That's it. That was treated with amoxicillin, child recovered. But any stormy presentation, initially itself, be very, very careful. Think of it. Discuss with your intensivist and all that. We do so many investigations in ICU. We can also draw the blood for an IVIG. And sometimes just after giving IVIG to that child recovered. Then the antibiotic started working. So stormy initial course, be very, very careful. It can be the early first presentation of the inborn errors of immunity, like a Bruton's and all that. So that's about the pneumonia. That's all I wanted to share with you. If there are any questions, definitely we can discuss. If I know the answer, definitely be more than happy to answer. This is one question that I wanted. I've always been wanting to ask to the audience, the learned audience like this. We use the word PBB, right? Protracted bacterial bronchitis. What is protracted bacterial bronchitis? Any child who has a moist or a wet cough for more than 3 to 4 weeks, there is no other, moist cough or resolution of cough with antibiotics and absence of any pointers suggestive of an alternative specific cause of cough. How did this child develop a protracted bacterial condition? What is the mistake that I did? I've been seeing that child for the last 4 weeks. Because we have been taught in the first 1 or 2 weeks that the child has a moist cough, don't start an antibiotic. It may be something else. It may be just a simple viral bronchitis. It may be an allergic bronchitis. Keep on giving inhalers, nebulizations and all that. Did I miss the bus? I think I must have missed the bus. Because look at the bacteria flora and PBB. It is the same as an acute bacterial pneumonia. It is the same antibiotic I'm going to use. Now here I use co-amoxicillin for about say 2 to 3 weeks, the child gets resolved. Here I was just going through the textbook, I just wanted to share. Why about 10% of children with ABB develop PBB? So these are some of the reasons that I was able to get. Because some of these children who go on to develop PBB, either they would have had a mild tracheobronchomalacia are secondary to infection. In the second, third week, they develop tracheobronch. It can be primary or secondary. And a subset of these BBB the children also have an innate immune dysfunction. So these are probably some of the reasons why a child with acute bronchitis progresses to PBB. So can we make a diagnosis of ABB in our clinical practice? In the first 10 days, 14 days, child there is no fever, nothing, but on examination you are only moist, you are totally crept, and the mother says there is no wheezing. Again, what is the thing? Innu kafat sound, doctor. Gora 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 sound is there. Mostly rattle, no wheeze. This is something that we can discuss little later. And of course, there is a role for antibiotic. When I was just reading the textbook, he mentions antibiotics can be given without fever and all that if the duration of cough is more than 10 days, plus the child has associated rhinosinusitis. But sometimes we may have to be careful, even if there's a rhinosinusitis, if there's only crepitation, no wheezing, there's a moist cough, we have to give it a serious thought to prevent BBB. We may have to put the child on antibiotics. I think that we can discuss later. I think with this, I come to the end of my talk. This is what I have read in the last couple of weeks. Again, Harrison, Nelson. And this is the book that I bought. The third book, then I just checked with Dr. Srikanta. He said, sir, you please buy this book. It's a fantastic book. Please buy this book. Everything, even they read the same book. So you can all become very good pulmonologists. Of course, not like Dr. Manjunath, but it's a fantastic book. I already read about half of it now. So it's a very good book, and some journals and up-to-dates and some online articles. Thank you for your patient hearing. I think I'm done. Good. Questions in the
Nagesh, all fine. So one of your carry-home message, Uganda study.
Uganda study, yeah.
40 CRP and then...
Yeah. That should be taken with a pinch of salt, because basically,
That should not be message.
No, I just said, so the importance of these clinical signs.
The thing is, we are all practitioners. Some of things will remain on
No, that is not the carry-home message. In that study, they give so much importance. Yes, Dr.
See,
Kash.
studies have shown that if you have signs of LRI with a CRP of at least 40, there's a high correlation to pneumococcal etiology. In
Yes.
fact, in some of the vaccine studies, this has been taken as an endpoint.
Yes,
I think
yes.
CRP is important.
Yes, yeah. This is one of the important acute phase reactants. Okay, because in the clinical setup, Gnan, so this can be.
Just the fever and CRP alone.